Hi, I'm happy to be standing here today to present my PhD topic about tissue acquisition in solid pancreatic masses. Here quickly I would like to thank my team for their valued support and help always. My vision is to improve diagnostics of pancreatic cancer, which will lead to better outcomes for the patients. And my mission is here to contribute to clearer guidelines for more efficient diagnostics for pancreatic cancer. I have two projects, both of which are about diagnostic adequacy and tissue acquisition. The first one is comparing different needle tips for the tissue acquisition. Currently, I'm working on my manuscript without final results. As a quick background, endoscopic ultrasound-guided tissue acquisition is a common diagnostic method for pancreatic masses. 10% of samples are inadequate for analysis, leading to a need for resampling. This carries a risk of adverse effects, needs sedation, and costs of about $2,000 per patient. There are 5 available needle types or needle designs: the standard Engh needle, 2 Westcott needles which have a cord trap, a tissue trap. One is forward beveled, one is reverse beveled. And then there are 2 new needle tips which are the crown cut needles, the Francine and the fork tip. There's currently not that much info in the guidelines. They suggest to use 19-gauge FNA or FNB needles for core tissue specimens or 22-gauge FNB needles. But the evidence here is low and the recommendation is weak. So my aim is to compare the diagnostic yield and adequacy using any needle in endoscopic ultrasound-guided tissue acquisition. The clinical question is if endoscopic ultrasound-guided tissue acquisition of pancreatic solid masses with any needle has a better diagnostic adequacy and specimen yield than with any other needle. I'm looking at a population of patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass, comparing any FNA or FNB needle and looking at the outcomes of diagnostic adequacy, specimen yield, number of passes, adverse events, and technical failures. My hypothesis is that there is a superior needle among the needle types. We started off with around 3,600 records, which we decreased down to 78. However, we updated the search on May 5th because more RCTs were published. So quickly about the outcomes, we weren't able to analyze all our desired outcomes. However, we have a network for histological adequacy, which you can see here, and a ranking which shows that the fork tip needles and the Francine needles were the best and the Engh needles were the worst. We decided to take the needle size out of the equation because we hypothesized that it doesn't affect the results as much and found that the fork tip and Francine needles are superior. They're also the newest, and the Engh is by far the worst. Here just quickly our net league table, which is color-coded. So the light red colors are worse, but not statistically significant. The light green colors are better, but not statistically significant. Any kind of solid color would have been statistically significant, but nothing actually was. We have another network for cytological adequacy. We were also able to establish a ranking taking sizes into account. Here we found the fork tip was the best, the Engh was the worst, and taking size out of the equation, we found, again, a very similar ranking with fork tip and Francine at top, and reverse bevel and Engh at the bottom. Here, just quickly, a forest plot which compares all the needles to the 22-gauge Engh, which was the most common node. However, again, nothing was actually significant. The same with the net league table, no comparison was statistically significant, unfortunately. So for the outcome of technical failures, we, again, have a network. We have a ranking which shows that Francine is the best, reverse bevel is the worst. However, technical failures were very rare. Most studies had a 0 event rate or one of about 100 or 200. So it's not really a cause for concern. Here we did have some statistically significant results showing that the reverse bevel was significantly better than the Engh. Further taking size out of the account, we find that the Francine is the best, reverse bevel is the worst, the other needles fall somewhere in between. For adverse effects, which was a little bit of a complicated outcome because the studies had very different definitions, we again have a network. we have a ranking which shows that reverse bevel is the best and Francine needles are actually the worst. However, again, there was a very, very low event rate, so it did not actually matter too much. Taking size out of account, we found that reverse bevel was the best, Francine was the worst. Again, net leak table shows that absolutely no comparison was statistically significant. However, we were able to compare most needles. In summary, the strength of this meta is that it's a network meta-analysis including more than 50 studies and thousands of patients. We compared all the available needles for endoscopic ultrasound-guided tissue acquisition of solid pancreatic lesions in several sizes. However, as a limitation, we have a high uncertainty leading to wide credible intervals. There's no statistically significant differences due to the uncertainty. But as a conclusion, I would like to say that fork tip and Francine needles are the best for achieving adequate samples. Westcott needles carry least risks of adverse events, but these are rare, so we should not take these into account too much. In summary, as implication for practice, we think that fork tip or Francine needles should be chosen if adverse effects and technical failures are not of concern. And the 22 gauge or 25 gauge fork tip is best to achieve a tissue core. As an implication for research, further RCTs comparing several needle types should be performed. Adverse effects should always be clearly defined in future papers, and adequacy for tissue cytology and tissue core for histology should be reported separately. My second project is about the diagnostic adequacy of tissue acquisition of solid pancreatic masses using contrast-enhanced versus conventional endoscopic ultrasound. Contrast-enhanced endoscopic ultrasound leads to better visualization of the tissues, but it also decreases the time window during which sampling can be performed. Therefore, our question is, does this increased visibility but reduced time window improve or worsen the diagnostic adequacy of the samples taken? So the clinical question is, does contrast-enhanced endoscopic ultrasound-guided tissue acquisition lead to higher diagnostic adequacy and specimen yield than conventional endoscopic ultrasound? Again, looking at a population of patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass, comparing contrast-enhanced to conventional endoscopic ultrasound and looking at the same outcomes, which are adequacy, specimen yield, number of passes, and adverse events. Our hypothesis is that contrast-enhanced endoscopic ultrasound is superior to conventional endoscopic ultrasound. So just as a quick progress, as of today, we have our figures and tables, we have our results. We're working on the risk of bias assessment. However, we were only able to pool 2 studies. Hopefully we will get data from a third one which was eligible but didn't report the outcomes in a useful way for us. Did not have any significant results. However, the third study might change this. To sum it up, I would actually like to finish and submit both of my projects this month now. It's officially June. And I would like to thank you for your attention with this ancient German proverb that a good paper tells a story, but a published paper cites reviewer 1, survives reviewer 2, and buys reviewer 3 a beer at the next conference. Thank you for your attention.
Can you remember from the articles what was the main way of getting the tissue? Was it a slow pull technique or a vacuum technique? Does it give any difference? Do you have any studies which compares these 2 main tissue acquisition methods?
I found many studies like this. However, I actually excluded any paper that used different methods because this wasn't our question. And also if they use different methods with the different needles, they were excluded as well because we were interested in the effect of the needles. However, I saw that there's actually a lot of many studies comparing this, and it's interesting to me as well, so I'm considering it as a third project, perhaps.
Because it is also might influence within each type of needle, it might give some different result. And so I think in the guideline it is a vacuum, but in the practice we are using mostly the slow pull because it is gives us less bloody tissue actually. So what was the majority of your articles? Which technique, do you remember that?
There was really a vast. I mean, it was just very different in every paper, and they had different styles of fanning as well. Different. I mean, it really varied by paper.
To check whether you can perform subgroup analysis between the different techniques because it might influence quite a lot.
I mean, unfortunately, it's already clear that we won't be able to form any subgroups because we already struggle setting up a proper network, because there are just too many nodes, too many interventions that we're already comparing. That's why we took size out of the equation. We want to do one more network which compares only the sizes, but it's really hard to take any other influencing factor into account. We will report the different methods in the paper, so we will give a comprehensive overview over the studies included, the techniques that they used, and how that might have influenced things. But we won't be able to address it in this project, unfortunately.
In that case, it should be discussed in details, actually, at the end of the article.
I have a question about the rate of complication, because this is the most serious information which we need also in clinical practice. So which needle was connected with the highest rate of complication, and if there were some major complication like a serious bleeding or death?
There was only one paper in which there was actually a serious complication, which was a severe case of pancreatitis. But mostly the adverse effects or the complications were just bleeding or pain. I mean, mild bleeding. It was basically, that's why my suggestion is to not consider these when choosing the needle, because they're so rare. At least they were in all the papers included. We ran into a statistical problem here because we were having so many zero event rates where both arms had 0 events, in which case it becomes complicated to do the statistics because you really don't know. So that's why my suggestion would be to actually not consider that too much when choosing the needle.